Tēnā koutou, tēnā koutou, tēnā koutou tātou. I'm speaking on behalf of the Sing Your Lungs Out group, and I'm just the warm-up act, actually. And they're all really hot and ready to go when I've finished. So we've heard today about chronic lung disease, and the respiratory strategy looks at ways that we might improve the management of chronic lung disease looking forward when the population of older people with chronic lung disease is growing. I'm going to use an illustration of a patient and the example of the singing group as John says, a non-pharmacological intervention that's patient-centred and community-based. So introducing Ken, a patient typical of the patients that you will be familiar with in your practices, referred to the respiratory clinic, 65-year-old, recently retired builder with a diagnosis of COPD. And as we can see from his breathing tests, we would call that a very severe airflow obstruction. So at the time that I met him in the clinic, he's already lost his reserve, and the activities of daily living are hard for him. He's now quite limited. So this is how I see COPD. COPD comes in many different shapes and sizes. We all know that. You all know that. When you see COPD patients, they're all very individual and no two are the same. And the reasons for that are obviously complex, as we've heard this morning. It is complicated, but involves a variety of biological disease processes and clinical expression. And we know that some patients will have a lot of emphysema, some will have a lot of suppurative lung disease. Some will also have important, and many, in fact not some, many will have important comorbidities. I've highlighted two of the current hot topics in COPD, if we can call them that. One is the eosinophilia, either in blood or sputum. You'll be hearing a lot about that as a measure of, or an indication of airway inflammation, and perhaps therefore indicating which patients might respond best to corticosteroids. And the other hot topic at the moment is the influence of early development on our lungs, both in utero but also in early childhood. It's no great surprise that's going to influence lung capacity and lung development, but perhaps also the impact and predisposition to the development of chronic lung disease. But I've missed something out of this slide, something we really talked about from Lance this morning and came into lots of different studies. What have I missed out here? Sorry? Exactly. The social determinants of health. Because actually, this is probably this and doctors and hospitals and inhalers. That's all 10% of people's health. And the rest is all the other stuff, the housing, the level of education, your genetics, behaviours, smoking, drugs, alcohol. Okay, so in terms of managing Ken, we know that we have got the three strong evidence-based interventions, and we know that they're all economic, very, very cost-effective. You know, influenza vaccine, the most cost-effective intervention, smoking cessation, and then pulmonary rehabilitation. And then we've got another lot of different interventions and managements and drugs that we would individualise on a sort of personalised medicine basis. And as we've heard about today, overall that really increasing over the last 10, 20 years is self-management, which has grown enormously. And we've now got COPD patients with back pocket prescriptions for antibiotics and steroids, for monitoring their lung disease and their inhalers. I would just say, or let's just think though, we're focused here on respiratory disease. Just imagine what it must be like with COPD self-managing when you've also perhaps got diabetes. So you're doing your BN sticks and you're doing your insulin things. And you've also got heart failure, so you're looking at your ankles and you're weighing yourself, and do I take one furosemide or two? And maybe you're monitoring your own blood pressure. And maybe you're on anticoagulant because you've got atrial fibrillation and you're either having some blood tests or whatever and checking the dose of your warfarin. The hospital nurse is sending you a text and so forth. Quite a big burden, I think, on an older population who maybe don't have that great health literacy. It's easy for me, I think about these things, but gosh, just reflect for a moment what responsibility we're putting on the patient. And with the definite feeling that you've failed if you end up admitted to hospital. There's a sense of failure if you end up at ED or need to be admitted. Okay, that's a sort of visual way of looking at the cost effectiveness of the interventions for COPD. This was a collaboration from the London Respiratory Research Centres and the London School of Economics, and they did a lot of really good work calculating the cost effectiveness of these interventions. Okay, so Ken stopped smoking around the age of 60 and saved himself thousands of dollars. The practice very effectively got him onto an influenza vaccine program, and that was going nicely. So then the practice, the GP and the nurses talked to Ken about pulmonary rehab. So how do you think that went? So how would it be, Ken? We'd like to go up to the hospital. They do this like group exercise program. Now, you know, without wanting to be too stereotypical, 65-year-old retired builder, what do you think his response would have been? No, not for me, thanks, but no, thank you. So one of my first things when I see him in the clinic is to kind of convince him about pulmonary rehab. And so I will say a few things. One is no lycra, no mirrors, no competition. And I'll say to him, we're going to treat your muscles to treat your lungs. And I know nothing about cars. I don't even own a car, actually. But I will say, your lungs, they're like the fuel delivery system. And your muscles, that's like the engine. So the better tuned up your muscles are, you're going to get more miles per gallon. Okay? And he might understand that. So he went along. And as is often the case with these patients, he became a champion of pulmonary rehab. It was the best thing he'd ever done. He told everybody, friends and family and everybody about it. And he went on from, he did really well and, you know, got a lot of health benefits from it, besides just enjoying it. And he went on to graduate into an ongoing exercise program, a weekly pulmonary rehab exercise program in the community. But about a year later, he came back to the clinic, and then just over the winter, things had not gone so well. He'd had at least one admission to hospital, and through that, deconditioned, and then they've gone into that kind of spiral that we all know. They decondition, they do less, they decondition, they do less. So that now he was very limited with everything he wanted to do at home, feeling really low and really quite miserable. So this is the point, and you could argue we should have done this sooner, but this is definitely the time when we turn away from the computer and the spirometry tests and you have that conversation with the patient about what really matters, what really matters to him as a person. And this comes back to what Lance was saying this morning, that whole having a relationship and deciding where we go from here. So he'd retired at 65, and his plan, his goals and his dreams of what that life was going to be like was that he was going to have more time with his wife and family, got sons and grandchildren. He got some projects he wanted to do at home and in the garden, and he had this amazing workshop with tools, and he'd got the idea he was going to teach his grandkids how to work in the workshop just like his granddad had taught him. And lastly, he was really, really looking forward to Tuesday mornings with his mates playing golf. Now, I don't think that's actually overambitious. I mean, I've got colleagues and they want to climb mountains and go around the world and run marathons, you know. But I think this is really realistic kind of goals and aspirations for someone at 65. It would have been lovely at that stage if I could have said to him, hey, there's a men's shed COPD group in Miramar just for you. Or there's a COPD golf group that meets in Karori, but there wasn't. But what I could offer him was to come and sing in the COPD choir. Now, how do you think that went? You know? But I can be very persuasive. And sure enough, along he came. So we set up the COPD choir about a year ago, just last October. We hold it in the Newtown Hall. So this is real world, in the community intervention. It's very low cost. The Newtown Hall is owned by Wellington City Council, so they rent it to us for a very low fee. But we do pay our musical director, that's Ruth. Oh, sorry. Oh, sorry. Oh, back. Got to press that one to show you Ruth. There you are, the musical director there. This was the first Noble, I think there might be 10 or 12 of them there. The first week there were just 3. I mean, what courage. That was amazing. But then it built up to 10, 12, and then, as you will see shortly, up to about 26 now in the choir. And this is what they look like now. And somewhat surprisingly, they have a very active Facebook presence, including a very famous T-shirt on tour. They themselves are not going to go internationally, but they have a T-shirt which gets taken around the world and suitable photographs taken. Okay. We were lucky to have Prof Beasley and the Medical Research Institute to back us to do this as a piece of research, as an intervention. And my theory, based on a little bit of stuff that had been overseas, was that perhaps singing, with the prolonged expiratory phase that you do with singing, might actually deflate some of these patients. You know, they're hyperinflated, and that we might take their breathing down, press the right one, might take their breathing down from breathing up in here to a bit down in more into the normal range. So this is the residual volume here. We might actually deflate them a little bit. So Prof Beasley and the team at the Medical Research Institute allowed us to do some full lung function on these patients before they started the singing group. So that includes the lung volumes, you know, they get into the box and so forth. We also did 6-minute walks. We did lung disease symptom score, and we did the HAD score that you've heard about also today, the hospital anxiety and depression score. Because my other theory was that we were going to make these people happier. After all, happiness is singing in a choir, and we might improve their mood. So my 2 primary endpoints were going to be residual volume and depression score. It became clear very quickly that that it was very popular, that people were coming every week no matter what the weather. We had the stormiest Wednesdays ever, and people would come. They'd rearrange hospital appointments so that they could come to the singing group. Their families knew that Wednesdays were protected and so forth. So we knew that we needed to measure other benefits, and so we've also set up a qualitative study where we've done in-depth interviews with at least half the patients, and are going to do a focus group on the others. So yes, we thought we might reduce air trapping and breathing control, but through the themes that have come out in the qualitative study, we're aware that it's had a lot more profound and wide kind of health benefits. In particular, it's a very, very black level of humour. There's things that they laugh about there that they would not do in polite company. Lots of laughter about death and dying and lung disease. Purpose is a big thing for these people. That's another very strong theme that's come through in the qualitative study. And obviously a very strong and resilient feeling of community. And then the other theme, and I haven't put an abstract noun for it down on this slide, but it's very pertinent to this audience, a very strong theme that's come in the qualitative study. The patients describe coming to the singing group as coming to somewhere where they feel cared for, where they feel nursed, It's a safe place. It's a third space. I don't know if you've heard that term. It's not work, it's not home. It's this safe third community space where they feel cared for and nursed. And when we set the singing room up, I didn't want that. I wanted it to be an autonomous, independent unit that would carry on. We would study them for a while, and then we would walk away and they would continue. I didn't want us, the nurses and the volunteers and me, to be too much of a presence. In fact, I tried not to go very often. But in fact, what's come through very strongly in the qualitative data is that it's that feeling of being relaxed, being themselves, and being cared for that's been very positive for them. So just going back to my point before, I pointed at this. Oh, sorry. Where we talked about self-management, and we put the burden of self-management of not just COPD but many other conditions onto the patient. And then there's a sense of failure if they come to the hospital. It may be that there's some room in the middle there where we need to provide care and nursing within the community. And it may be that through community groups and activities, and the singing group is just one example of that. So this is our research team. I need to thank Richard Beasley, Matthew Williams, and the research team at the Medical Research Institute. Financially, we've had funding from Wellington City Council and from Infinity. This is Ruth, our main choir director. We're lucky today to have Mark all the way from Denver, Colorado, to conduct the choir. And we've had an amazing collaboration with the local boys' college. This is Wellington College, just over the hill from Wellington Hospital. So these are senior boys that sing in a really fantastic singing group called the Chorale that wins awards and things. This is Katie McFarlane, their head of music. And they've taken on the singing group to support this year. So they've been paired up with patients, and then they've come to support them when they've done public performances. And that's been a very heartwarming, lovely collaboration and cool community building also between the generations. So are they ready? Okay, that was the warm-up. So presenting Sing Your Lungs Out.